Can I start, Josh?
Okay. All right, everybody. Thanks for coming. My name is Josh. I'm a physical therapist here at Physical Therapy Centers, St. Peter's. And this is Demir. He's the owner. And Morgan up front is our client care specialist. And that's our team here at Physical. So we opened in June, and today I want to talk to you about what Physical is, what we do, and give you guys the opportunity to hopefully benefit from this presentation at least, and maybe come to physical therapy here eventually as well.
Are you or a loved one scared to take the next step? Are you feeling dizzy or experiencing vertigo? At Physical Therapy and Balance Centers, we believe balance is core to your wellness. Our team is here to help you reclaim independence one step at a time with our proprietary balance and vestibular programs. By navigating real-life scenarios, our therapists will help you increase your strength and confidence and ensure you stay safe in any environment. Contact us today.
All right, so we're here at 231 Salt Lake Road in St. Peter's.
Are you or a loved one
Go to the next slide here. Today we're going to talk about falls, try to give you some ideas of how to kind of prevent falls, and talk about why falls are so catastrophic, and then talk about what we do to try to prevent falls as well, some of the tools we bring here at Physical Therapy. So I was talking to some people before. I got a bachelor's of exercise science at Oklahoma Wesleyan University in 2013. Then I went to Missouri State University in Springfield, Missouri. I started working for the government for a while, got certified to treat lymphedema because I saw a lot of people with lower extremity swelling, which is also a big part of what impairs balance. And then I went out and worked in New Mexico for the Public Health Service and got a master's of public health and epidemiology from the University of Arizona Online. And now I'm back in the St. Louis area and working here as a lead physical therapist at Physical. So I try to bring all those things as much as possible to the table to try to help my patients and clients get better and look at their swelling, look at their vestibular system because of the expertise here, and try to help you prevent falls, because falls are so catastrophic. You can see here from all these statistics how much falls impact our country and our lives. So every 11 seconds somebody falls. 1 in 4 adults fall each year that are 65 years or older. So it's a big problem as well as monetarily, with $67.7 billion in combined medical costs associated with falls annually. And falls are the leading cause of both fatal and non-fatal injuries in older adults. So these are what we classify as unintentional injuries, and that's a significant cause of death on the CDC's top 10 causes of death. It makes up, this fall category makes up one of those pieces of that unintentional injuries cause of death. So we want to deter this because the cost in life years is really a lot. So people can lose a lot of years of their life from a fall. And the fear of falling is something that we deal with here at Physical as well. Our overhead system really is designed to try to eliminate that fear of falling so that people can help people regain their balance. If you're afraid of falling, you often will avoid moving, and we want to get you back to moving. So our overhead systems here allow us to help you kind of eliminate the fear of falling. The most common outcomes of a fall, you see a loss of independence. The fractures are really bad, especially big bone fractures like the hip. That's a big cause of pneumonia and a cause of death among older adults. So financial impact, we talk about nationally a lot when we use the big numbers because everybody likes big numbers, but personally, if someone doesn't have the coverage, if they have a huge medical bill, it can be very catastrophic as well. So that's something often that doesn't get talked about enough, is the financial burden on the individual. And then the development of comorbidities from that. If we have decreased mobility as a result of a fracture or injury, total hip replacement, something like that, that can cause people to stop moving as much, and it can contribute to other diagnoses that can shorten a person's life. So again, we try to prevent the loss of independence. We want our patients and clients to be able to do what they want to do when they want to do it. So on this one, you can see that falls are going to be going up. They're currently in the process of going up. When I was in school, people were always saying physical therapy is going to be a great profession because the boomer generation is getting older, so you have lots of clients and you'll have job security and healthcare and all this. So, and that part is true. There is a lot of job security in healthcare compared to some other fields, but we can see that this issue of falls, it's just a reality of the size of that generation in the United States. And so we want to be able to address this problem and get better at decreasing falls as this population gets older, because we need that knowledge and expertise and wisdom from that older population. And selfishly, people want to live longer, right? So it's not always about sharing wisdom. Sometimes it's just about enjoying your life and living longer. So we can see that this problem is getting bigger. It's not going away, but we're bringing new technologies and new tools to try to address these issues. So quite simply, that the fundamentals, falls are not an inevitable part of or normal part of aging. So you can see that some people do a much better job of preventing falls as they get older, and these are people who tend to be more aware of the factors that we're going to talk about here. So your physical factors, these are things that people usually know about. Are my muscles weak? Are my muscles flexible? Am I moving? Do I have neuropathy? Right? These are things that people think about a lot, but sometimes they don't think about where the muscle weakness is coming from. It can come from a stroke, a brain injury, it can come from a nerve impingement, it can come from the weak muscles themselves. A lot of times, people attribute muscle weakness to sedentary lifestyle, and that may not be it. It may be other things. So we try to dig into these things with you when we do an exam. We try to see what, on an individual level, are you struggling with the most, and try to give you a evaluation that shows you kind of like a roadmap of this is where I'm weak, this is where I'm strong, and this is how I improve my weaknesses and leverage my strengths in order to reduce my fall risk. So medical and medication factors. This is a big part of working with your doctors closely, considering side effects of medications, having long conversations with your doctors about, even though it's very difficult to keep them in the room sometimes, you want to have those conversations about what the side effects of your medications are, why you're on them, make sure you really understand why you're on each medication and what the potential side effects are. Environmental factors, this is one I like to talk about a lot, because a lot of people don't think about these things. I know it's come out more and more, I think in recent years, that we need to remove throw rugs, we need to have well-lit night lights, you need to reduce clutter in the house, beware of pets, these types of things that can trip you up. And then, cords and those types of things. You can tape your cords to the ground if they're, running across the floor. But a lot of times we don't think about how to design our environments to try to help. So one thing we'll go over, if you come into physical therapy and have a hard time getting off the ground, we'll talk about how to get up and off the ground. We'll talk about, arranging chairs and arranging your furniture in a way where, if you have a hard time getting from point A to point B, you have a place to rest, or you have a chair to help you get up if you happen to fall. And I like to talk about, your social environment too. My master's in public health and epidemiology, I like to try asking about your relationships and different things, That's one thing I like about having these events, is to have you all talk to each other too, because we glean more information from each other and do better when we have a social network. So behavioral and lifestyle factors, this is one that is really important to talk about, because some of us just tend to be more ADHD. I can have that too. And it doesn't go away all the time as we age. Sometimes it can even get worse. So multitasking and rushing and not really focusing on one task at a time can cause issues and increase our fall risk. And then, everyone knows about lack of physical activity, I feel like, but it's just such a hard one to implement with our environment. So I like to talk to you all about diet and, trying to figure out little tips and tricks to improve your diet and help with weight loss, because I know that gets harder as we get older, and it's one thing that I'm very passionate about because I see how our environment kind of sets us up for failure in the diet category. So I try to talk to you all about that a lot too, as we have time. And then of course, like limiting your exposure to toxins or certain chemicals and drugs. So we'll move on here. So I want to talk to you about kind of move away from the more lists of things that can help you. A lot of these things we can talk about, but they're not going to really make an impact on your life unless we integrate them. So that's a part of what physical therapy is. We're trying to figure out what are you actually going to do every day. What are you going to be consistent with? Like I tell my patients, consistency is the key. So if I give you an exercise and you don't want to do it, then it's not going to be very helpful. So, but if we can find those things that you are willing to create a habit and make it part of your routine, your daily activities, and it helps you a lot, that's the sweet spot. That's what we want. So when we're doing vestibulo-ocular reflex, this is something that has to do with your vestibular system. It's the 3D, I call it the 3D leveling system in your head. So you have one in each inner ear. So a lot of you have heard of it called the inner ear. And it tells you where your head is when your eyes are closed and you move your head around. So it's kind of like an accelerometer. And what it does is it functions on gravity, and it tells you, hey, my head's on the side or this way. That has to work in tandem with your eyes to track objects in space. So this vestibulo-ocular reflex is an important part of maintaining our balance, especially when we're moving our head or we're moving our body, especially when we're doing both at the same time. So I want you to try this exercise with you. You can all do it sitting down. It's not hard. If you're sitting down, it's very safe. So you're going to stare at your thumbnail one arm length away. So you're just holding the thumb up. And then you're going to turn your head side to side every second for 1 minute. Okay? So 1, 2, 3, side to side.
Do we keep looking at the thumb?
So yeah, you'll keep looking at the thumb. So you're staring at your thumbnail the whole time. And it's just like, you can set a metronome to do this. So what I'll do with the patients is set every 1 second. So I'll just count it out for you. So let's do side to side, rotation. So not side bending, but just side to side for now. So 1, 2, 3, 4, 5. Every 1 second you want to go back and forth. So every time my hand's hit, you're going to be going back and forth. To make that more difficult, you would speed it up. So if you want to try it. Okay, so that is the vestibulo-ocular reflex, and that's what we call the VOR exercise. Okay, just VOR for short. So what that's doing is it's trying to train you to track objects in space. And what you want to do is you want to find the sweet spot. And that's something we discuss in therapy. It's something we prescribe if we see issues with your VOR reflex when we test it. Another thing that we can prescribe that a lot of people really would benefit from if they do it is the one-legged stand. So if you all want to try this, you can. But what I will say is some of you will need to do, I'll show you out here so everybody can see. Some of you will need to just stagger your feet, okay? Because that'll be difficult enough. So you just have 1 foot forward and 1 foot back. Just kind of like you're taking a short step. Other people will be able to do feet 1 foot right in front of the other. Some other people will be able to put 1 foot down and the toe down on the opposite leg. And then some people will be able to do a single leg stance. But everybody start here, if you'd like to try it, and then move your feet inward before you attempt single leg stance. So if y'all want to try that, you can hover your hands over the chair in front of you. Go.
I'll try. Try to hold on to something. Just
Yeah, I got a neuropathy.
don't push.
Yeah.
Yeah.
So I can step right in there. Just gonna stay inside. That way, so this is This is a great example of how you would practice this at home because you want your kitchen counter in front of you and then a chair behind you. If you're gonna practice at home, you wanna be safe, all right? So hover your hand over, your left hand can stay over, your right hand can stay on the cane. Yeah, go ahead and try putting one foot slightly forward.
There you go.
All right, now, if anyone wants to try, if you feel confident, you can try putting one foot right in front of the other foot. That's what we call tandem stance.
I'm 54 years old. This hits me as soon as I close my eyes. You know, I close my eyes and, you know, I'm out of shape.
All right, and then if I will discourage some of you from doing it, but if anyone wants to try the toe down in the back with the front leg on the ground, that's pretty good.
Is it?
Yeah.
I feel wiggly.
And then single leg stance is the next phase, but I would say most should not try that right now.
That she's young.
So,
I get a lot of practice working here.
Morgan's doing great with it. All right, so that's basically a very quick way to practice your balance, but the key is to find the sweet spot. All right, we want to find the spot that you can ideally balance. What I tell people is try to find the one that you can do for 10 seconds at least without losing your balance. And then practice that, okay? And try to get it to 30 seconds.
So you mean keeping your hand off the chair?
Yes, you should not have to use anything but your feet. Yeah.
Should be able to do both sides, I guess.
The objective is to train yourself so that you can do single feet, eyes closed for 30 seconds, which I can. So,
Well, I mean, that's the next phase. Just worry about eyes open until, yeah. So you have to be, so there's lots of ways to make these balance exercises more difficult. The key is to find what I call the sweet spot. So it's the idea of, basically there's variable practice and then there's mass practice. That's how we describe it in physical therapy and sports. And it's like when you're doing, you don't want to do a bunch of different exercises too soon. You want to focus on, really improving on one thing that you need the most before you go to what we call variable practice. So mass practice is I'm going to do this one thing or these 3 exercises over and over again and get better at them. And then variable practice is now I'm going to make all those things a lot more difficult by throwing in different variables or more degrees of freedom, okay? So yeah, the close your eyes, that's a very more advanced one. Eyes closed, single leg stance is, to be able to do that's really good. So that's something that would take a while to get to. And here you can see there's lots of ways to grade these. So what they do is they go and they find a bunch of people that are relatively healthy and meet the standards for a study, and then they can test and see, okay, who has the highest fall risk or who has had the most falls, of this group, and then they can test their single leg stance time. So that's where this data usually comes from, is a study like that. And you can see that if you're unable to perform single leg stance, I could talk about this a long time, like I will if you come into therapy, but this is a big part of walking, single leg stance. So if you can't perform single leg stance, you're more likely to fall while you're walking. And you can see that people that have less than 10 seconds of single leg stance have an elevated fall risk. People who are unable to perform it have a high fall risk. So this is about, this is where the discussion goes not only from how am I doing to what are my risks. So it's kind of like you're looking at your life and you're thinking, how should I address these risks? And it's a risk management at this point. It's kind of talking about what can I do? How can I adjust my life and prioritize my health more in order to either, extend the amount of years through avoiding the fall or improving my cardiovascular health. You can look at your health in these ways. And this is how we start to kind of see what your risk is. So you can go through this list if you want. And I'm happy to kind of print these out for you if you want, but I'll give you a minute to all look at this and try to see how many, just go down the list and count how on your hands, how many you say yes to.
Can everybody read?
Yeah.
Would you like to read them?
Sure. Okay, yeah, we'll read through them. So I have fallen in the past year, yes or no?
Would you repeat that?
I have fallen in the past year. Have you fallen in the past year? Yes or no?
2 points.
So just go ahead and start counting on your fingers there, okay? If you have a yes, then just use one of your fingers to mark it, okay? I use or have been advised to use a cane or a walker. I sometimes use my balance when walking. So lose my balance when walking. Do you lose your balance sometimes when you walk? Okay, that's number 3. So if you get yeses, just keep on putting more fingers out in your hands. I worry about falling. That's number 4. Number 5, I use my arms to push myself up from a chair. Number 6, I sometimes have trouble stepping onto a curb. Number 7, my body sways when standing stationary. Number 8, I take short, narrow steps. Number 9, I stumble often or look at the ground when I walk. 10, I frequently have to rush to the toilet. 11, I have lost some feeling in one or both of my feet. And 12, my medication makes me feel lightheaded or sleepy. All right, so to make it easy, you can use 1 point for every finger that you have. If you've been counting on your fingers. The first 2 count for 2 points. If you've been advised to use a cane or a walker, or if you've fallen in the past year, you're already at risk for falls if you answered yes to either one of those. If you answered yes to both of those, you're already at high risk for falls. So, but if you answered yes to 4 or more of any of those, then you're at a high risk for falls. And some of those are more, there's a little bit more of a caveat to them. Like everybody sways a little bit when they're standing stationary, but you get more context as you explore the others. So if you scored a 4 or more, it's a good indicator for you to try to be doing things to, manage that risk. What do we do here? Well, I am commonly doing these when you come in. So this is a comprehensive balance and fall risk evaluation. So when my patients come in, I have 40 minutes at the most usually to spend during an evaluation. And I try to, as much as I can, use at least 10 or 20 minutes of the evaluation hour to address the home exercises part of it. So I try to give people something to take home with them the first visit, right? So if that happens to be the only visit they come in, they've got a home program to get started with. But what we do, we're working on trying to do more of these things to give you a more comprehensive eval, but we need more time in order to do it, right? So the way that we currently build activities, if it's a minimally complex, like the lowest tier evaluation is 20 minutes, the next one's 30, and the next one's like 40 or 45, really 45 minutes. It's a complex evaluation. So on a complex evaluation, I can go through most of these things, no problem, because I've taken 45 minutes with you to assess them. And I could go, kind of tier by tier on these, but I'll try to just hit a few of them quickly. So the first one, the fall risk assessment, is kind of like what we've been talking about today, except I'm going to ask you specific questions about your social history, your medical history. I want to know what surgeries you've had, what medications you're taking. The next one's where we start to get into the balance testing. I will do this on people if they say they've had vertigo, and if they say they have a lot of dizziness, balance issues. If someone presents and they say my issue is I have a total knee replacement and I've had issues with this surgery and everything seems to be muscle in nature, then I may forego some of these vestibular tests. The strength and mobility analysis, I'm always trying to get an idea of a quick screen of somebody's strength and range of motion. So I usually do something there. And I always try to do time-based tests. So if you get nothing out of this presentation today, know that the slower people walk, the higher their risk is for falls. So that's one of the best objective measures that we have in physical therapy. It's called gait speed. So if you walk very slowly, it's likely that you have a much higher risk for falls than somebody who's walking faster. That's one of the most objective measures in physical therapy, actually. Grip strength's another one, and then we have other ones that we're continuing to explore. Foot sensation. So I'll do a monofilament testing of your feet. We can do, we're working on getting more tools to do. Like I can take the temperature of your foot with our temperature gauge. We want to do more mapping of the feet. We actually have a foot scanner as well. We can kind of show the way you walk to see if there's an asymmetry in your gait. And then objective balance measurements. So these are the outcome measures. This is what the insurance companies want to see. They want to see especially what they call outcome measures, which are mostly subjective. It's just you and you're filling out a form telling us like how poor your balance is. I like single leg stance time, what we just did. That's a great indicator. It's another one kind of like gait speed. If you don't have a good single leg stance time, you're at much higher risk for falls. So I like the objective ones, the time-based ones, the distance-based ones, and you can even do cardiovascular ones called the 6-minute walk test, and like step tests if you're healthy enough. Step tests are great. You can measure, get an estimate of your oxygen or your cardiovascular health and your cardiopulmonary health, so your lungs more too. And then personalized treatment plan. That's where we want to really work with you. So try to ask you guys what it is that you can do. What is it that you want to do? One thing if I have a really good exercise that I think the patient needs to do the most, but then I have another exercise that I think they need less, but I think they're actually going to do it, that they like a lot more, I'll do that one instead. Because if you're not going to do the one that's the best for you, I'd rather have you do one that's a little bit less good for you, but you still really want to do. So that's something that I'm always trying to figure out, how do you own your health, right? Because we only get so much time with you. So if we only have so much time with you, because we're limited by, the amount of weeks that your insurance is approved for you to attend, that's fine. We'll get you maybe coming around the next year if we need you again. But what we want to do is help you own your health, help you really carry that over. Some people I see during the winter and then I don't see them again until the next winter, right? But it's discouraging when we see the same issues over and over again. We want to try to make as much headway on those as we can in the off time. And that's all about, for me, education and trying to figure out ways that you want to own your health in ways that you can, making goals realistic.
For him, this wasn't just another day. It was his granddaughter's wedding. Walking had become hard. Balance felt uncertain. But giving up was never an option. At Physical, we focused on what mattered most: strength, balance, and confidence. Step by step, he trained. He improved. He believed again. And on the wedding day, he didn't just attend. He walked in with pride. Physical, love your life.
So we like that video because it's a very that's part of the key, is attaching your health goals to an emotional outcome. That would really be helpful, right? A lot of patients that I work with, they want to travel, and that's something that they want to plan.
This wasn't just another
Sorry.
day. It was his granddaughter's wedding.
Do it again here. So they want to. A lot of my patients, they want to do. They want to go on a trip. Some of my patients, they want to go to Europe again, right? They've been traveling in the past, or they want to take a cruise. Or some people, it's much more kind of. It's just basically they want to keep driving, right? So there's all different tiers, but if you can attach your health outcome to like an emotional goal, it's going to be a lot more motivational than I want to get to this, weight, this number of pounds, or I want to get my, cholesterol to this level, or my, blood sugars to this level, or whatever. So we try to do that when we create our goals, and that's one thing that's like a part of the relationship with a therapist we try to emphasize. So here are simple exercises you can try at home. I'm going to demonstrate them for you quickly, and then we won't go through each of them together. But we already did the single leg stand with your eyes open. One of the most fundamental movements that I do with a lot of individuals is the sit to stand. So, thanks, Demir. So there's lots of ways to do a sit to stand. I'll give you all the a quick kind of lesson in it. So if you're just doing it like this, that's the way we want you to do it. It's to be able to go down slowly, barely touch, and come back up. A lot of people can't do this. So what you got to do is you got to start with using your one hand, or maybe two, right? So you can even have, if you have an assistive device that you use, you can push your walker right here, push off with one hand, stand up. Okay, you're using your arms to assist you. If you need to use both arms to push off the chair, that's what I tell my patients when I'm working in the hospital, is push up, then grab your walker. And a lot of them, it takes them that long to get up, right? But we practice that, because if you're not practicing, you're not going to build strength. So it's a functional movement that people need to do. And a lot of people struggle more and more with this as they get older, because we spend too much time sitting, and because we tend to accumulate comorbidities. Like some people have had a stroke, so their brain is damaged, so they can't, get that signal to their muscles. And so there's all kinds of different reasons. But one of the gritty parts of physical therapy is that you have to practice, even when sometimes you don't want to, right? And that's where it becomes more like, it can become like a battle to maintain integrity as we age, and to keep focusing on doing less, but doing it better, and doing it well, even though it's more and more difficult. So the heel toe walk, this is called, call this tandem gait as well. You just put one foot right in front of the other. If you did well with single leg stance, then this one is one to try. If you didn't do well with single leg stance, this one will probably be more difficult. But you put one foot in front of the other, same type of sobriety test that you see with the policeman on the side of the road after you get pulled over. That's very popular in our culture. So head turns while walking, that's another very advanced one. So when you're walking, a lot of times if you have trouble with the VOR, the vestibular ocular reflex, it's going to be harder for you to walk while you turn your head, okay? So this is kind of like, even with me, right? It can be difficult. So if you're not used to walking and turning your head at the same time, that's a very advanced one to try. But again, it's for people who have pretty good balance already. So for everyone, you should be able to do sit to stand practice. I mean, that one is the only one, people who are bound to a wheelchair or have to be in a wheelchair, they cannot do that one. But if you're using any type of assistive device like a walker or a cane, you can do sit to stand practice, and you should. So, and then, if you can't do the single leg stance, you can do just narrow your base of support like we did earlier. So if your balance or dizziness is not related to a specific medical condition, it most likely will improve with training. So that's what we're always trying to do. I'm trying to do that in the eval. Okay, what things are because of this medical issue? What things can we touch with therapy, and what things can we, improve? So that's part of our eval. We look for the things that we can really improve. And usually there's a long list, and the goal is to find the thing that will improve most quickly if we work on it. So what we'll do here at Physical is, I am the lead physical therapist. Crystal is our part-time physical therapist that works here. And either of us will do your eval, and we will, again, do the things we already talked about and try to differentiate what can improve and what can't. What are you good at, and what needs work? So, And you use it or lose it. I mean, I like this one because I work with patients in the hospital that have just had a big fall or just had a stroke, and it's very gritty. It's very emotional. Some people are in tears when you go to get them out of bed. Some people are resisting because they're so angry that they have to do therapy every day for 6 days in a row. And it can be a kind of a battle. Sometimes I have to try to be a lawyer, convince people, like a psychologist, to try to convince people how do you get them out of bed when they don't want to move, because they're in so much pain because they fractured their sacrum, or they're so discouraged because yesterday they could walk and do what they want to do, and today they can't move their whole left side, right? So there's all these issues that you see, and use it or lose it. That's kind of the attitude of, we have to decide how much effort, how much we really want to improve, and how much are we willing to do to improve it. So another thing that's really important to know is that you don't have to have a script from your doctor when you present the therapy. You can present the therapy and receive an evaluation and treatment. We have to have an approval after 30 days. So what we'll do is we'll evaluate you, and then we'll send our results to the doctor and say, hey, we'd like more therapy approved for this patient. And that's what allows us to have direct access. We do have to look at your insurance and see, if it covers the cost of an evaluation. But you can walk straight in to the clinic and be evaluated.
You often don't need to go to the doctor. We'll take care of everything for you. So you don't need to call them, schedule them. It's just not necessary.
Sure.
If I could ask a question, is there a range price-wise if your insurance doesn't cover your evaluation?
Yeah, yes there is, and we'll, so we have, our prices up here are $125 for evaluation and $95 for follow-up. And then we have,
$95 for what?
for a follow-up appointment. So the evaluation is gonna be a 40-minute eval, and then follow-up is gonna be a 40-minute session.
But if you already have a script from your doctor, then you don't need to have evaluation.
So you don't need-
Or you guys like to do the evaluation because you're doing the follow-up therapy.
So we do an evaluation with every patient that comes in here, every time they come to see us, because we need to get an understanding of your change in status. That's part of.
So what happened this past week? Did you have a fall? Did you do your exercises? If you did your exercises, talk to me about that.
Yes, and what is bringing you into therapy like today? Basically, that question. So insurances, they want a recent. It's part of CMS too, and it's a big rabbit hole to get down, but it also helps regulate and increase accountability. So there's a lot of positives from these things. So you have to have a date of onset, is what we call it. So the date of onset should be, recent. It shouldn't. That's a hard part of the discussion is people will say this happened 5 years ago, but I have to get a date of onset when they wanted to come to therapy because of a change in functional status. That's what we're looking for. So all that means is I can't do this thing that I used to be able to do, and I'm here because of this.
Currently.
Yeah, basically. And they want it currently. And some people have chronic conditions that they're still trying to improve, and so it's not always the most fair thing. But what I will do is, if you just went to your doctor and you had a conversation with your doctor, he's like, you really should, do some therapy because your fall risk is high. I will use the date of the visit to your doctor as, the onset, the date of onset. But we don't need a script. The date of onset can be when you come to therapy today, right?
You would help us with the date of onset.
Oh, absolutely.
It isn't something that we.
I don't even ask people what's your date of onset. I just ask them questions until they give me an idea of a date, and I put it in. Yeah. So,
Figured.
yeah, so a lot of these things I'm filling them in. Like I fill in the gaps, and we have you fill out a medical history form, which answers a lot of these questions too. But yeah, what I want to know is, what do you want to improve on, and how much do you want to improve on it, and then how can I help you do that? That's kind of where we're going. It's about your quality of life and safety.
Do you have conversations with the insurance people also, you personally?
I rarely do. Mostly it's gonna go through Morgan. She's our insurance expert. She knows more about insurance than I do. But what I'll do
The
is,
person from here talks to the insurance company.
I
about
have.
their symptoms.
I have, yeah. But,
You or someone else.
yes.
Yeah, I'll take care of all of
Okay,
it.
I got you.
Yeah, Morgan calls and talks most frequently, but I usually just talk to them if I need to, so.
One other important aspect is during the evaluation, we will record some specific measurements of your walking speed, standing speed, etc. And after given duration, let's say 12 weeks, you are expected to improve on those. So before and after measurements will show you how much progress you made. Otherwise, everything you did was useless, and that's what we want to prevent.
Because the insurance people don't have the knowledge about balance
Yeah.
that you have, that you two have.
Yeah,
So you might have to explain.
yeah, I mean, I don't wanna get into too much of a rabbit hole, but I do care a lot about those conversations, so my experience, there's great physical therapists that work for insurance companies that will help people get the care they need, but there are also policies that impair, people from receiving care, so that's a big rabbit trail that I won't go down, but we are on the phone with your insurance companies, trying to give them reasons why your, care needs to be approved if that's needed.
So if you've had a number of falls, or say you've had just one fall, but you ended up having stitches, you could say to the insurance company, they fell due to lack of balance.
Yeah, I mean,
Therefore, we want to improve their balance, and that's what we're gonna do for 12 weeks.
yeah, absolutely, yeah. So comprehensive 40-minute balance evaluation, that's our insurance-based direct access available. Morgan will help you schedule it and see what your insurance will cover, try to get an estimate of your copay. And then our workshop attendees will receive priority scheduling the next week. So this is something that we're offering you here today. So we want to, help get people in the door, help spread the word, and help prevent falls. So this is what we just talked about. It's a 40-minute evaluation, 40-minute follow-ups, and insurance covers it. But we also have another program that we're starting, that is our longevity reset program. So this is 80 minutes detailed evaluation where we go into bigger depth. I'm gonna screen a lot more because we're gonna have a lot more time. And we will do 40-minute follow-ups, the same amount of time follow-ups, but you have priority scheduling, full body mobility, flexibility, and postural evaluation. So instead of just, really honing in on one joint because I just have 20 minutes and I have to prioritize whatever was on the script or whatever, you said was your chief complaint, we can do more, look at more of your body and try to get a better whole picture of your health. So clear 12-week improvement roadmap, advanced balance and vestibular assessment with our IR goggles. We haven't talked about this very much, but this is called, these are infrared oculography goggles. It's a fancy term that just means that it's infrared spectrum of light, and it's allowing us to see your eyes. So it's an infrared camera that just films your eyes. You put the goggle on, and I watch your eyes as we do what's called vestibular tests for vertigo or other things. And that helps us to see better what your symptoms are and the signs are of your problems. So this gives us a better idea of your balance. We also have other tools that we talk about. Gait and foot pressure analysis, that's our foot plate, our foot mapping technology that's up front that we use to get a better impression of your gait. We can order custom orthotics through that as well. And then others when clinically appropriate. So I like to do lots of tests, grip strength testing. I like to do circumferential testing if you have swelling. I try to do that for most patients, screen to see if they have any concerning swelling. But we can do circumferential measurements. There's lots of tests we can go down if you're interested in focusing on weight loss or focusing on pain management. We can cater your therapy to do that. So I can work on creating a more comprehensive program for you with that increased amount of time. And before and after improvement notes at week 12. So what we do is we will show you, hey, here's where you were really weak before, here's where you were strong, and now here's your new map. We try to make it as objective as possible. It's really painful sometimes. Somebody gets to the end of therapy and, you know, they haven't improved their gait speed, right? Most of my patients improve their gait speed during therapy. But if somebody hasn't, then I'm like, what's going on? And that's where we really have to refer back to the doctor. But we try to make it objective, because if it's not objective, you know, it still matters. But, you know, because qualitative, you know, is very important. Subjective improvements are very important. But you know, we also want to be able to, everybody to see, you know, the improvement. And we want to show that to you at the end of therapy. So, so that's our program that we're starting today, and Jameer can answer more questions about that.
Can you show the overhead, safety overhead system?
Yes.
I think that's very important.
Yeah, so our safety overhead system, we talked about this. This is, I don't remember how much, do you remember how much it was to put in?
500 pounds.
Oh, 500 pounds is great for it. But
Yes.
it's also a very expensive system to put in.
Oh,
but it's really
35,000, yes.
Yes, so I like to talk about the price too, because it's important, yeah. So this is a harness here, we're gonna put it on Jameer, so you all can see. So I think these are, what I tell my patients all the time is I think these will be in clinics, like in the future. I think these will be very popular among our, people call the geriatric population, so our elderly, because we want to prevent falls, and this gives people a lot more confidence to work in therapy. And like a lot of people, when I looked at this, I thought, I'm a skeptic, so I'm like, hey, you know, is this really gonna be helpful? Because it's just holding you up when you're in the system. But what it really does, and what I've seen that it does for my patients, is it eliminates the fear of falling. So like Jameer said, it's graded for 500 pounds, so we can tighten it up and give it a little bit of slack, so it's not gonna keep you from moving. I'm gonna have you step over to the left, Jameer. There you go, perfect. And then I clip it in so you don't have a long tail. And you're attached up there. It was designed by a guy that was a climber in Las Vegas and had his own clinics out there. And it's a single point fixation, which I really like. It's a lot simpler than a lot of complex overhead systems you'll see in inpatient rehab facilities. And it's got two harnesses on the back, so I can grab the patient and hold them up if I'm concerned that they're going too far in one direction. So
that's kind of in lieu of the belt that goes around.
it's much better than a gait belt, because I've got 1, 2, 3, 4, 5, 6 straps around his body, and I've got 2 grips. And you can see that it totally supports you. And I've had patients do that during therapy quite frequently, and they're very safe, and I love it because it allows, this is what it does for people, it allows them to make mistakes without actually falling. So if you actually fall, there's a bigger fear, there's much more apprehension, and you can't think about what you just did wrong to cause that fall. But what I try to do is, as we're walking on this line, pretty much my favorite place in the clinic is all,
Yeah, this goes.
yep, it goes 20 feet, 22 feet I think. So I like to do a lot of tests right here, a lot of gait training right here, and therapeutic activities on this line. And what we focus on is, hey, what did you just do that caused that fall? And what just happened that caused that fall? You know, it may not be something you did, but something that, you know, is occurring because of your diagnosis or morbidity. And we try to identify that and then figure out, okay, what strategies can we implement now to prevent that from happening?
Because the problem is when you fall, you don't, people will say, what did you do to cause your fall? You have no idea what you did.
Yeah, that's exactly right.
And if you use something like this, with you present, then you know what happened to cause the fall.
And that's why we try to break it down with the test. So we assess your 3 systems of balance, which we didn't even get into in this presentation, but your vision, your vestibular system, and your somatosensory system. So your feeling, your sight, and then your sense of awareness of where your head is in space. And once we figure out which ones are really having the problems, you can start to work on those systems, but we leverage your strong systems as well to keep you safe. So, so I'll just give you one example of potentially many, but foot drop. Some people have, they're unable to bring their toes up, so their foot drags, right? And some people are unaware that that's starting to happen. And simply what we can do is say, well, I just saw you drag your right foot and then fall to the right. But some people they're not aware that that's happening. So what we do with this is like, they fall, get pulled up by the system, and then I say, okay, what happened? Just think about what happened. And then we talk about it. And then we try to, practice immediately. So it's like learning to drive. When people are learning to drive, they have immediate feedback. That's what makes learning really rapid. They've done studies on this. If we don't give people quick feedback when they're learning, they're not going to learn well. But if we give people quick feedback, then often that accelerates learning. So that's what we're trying to do with this overhead system. And, there's certain problems we can address very quickly. And there's other problems that we have to really say, you have to work on this over time. We have to prioritize this list of things in order to improve them. So, any other questions about?
There are many cases where the physical therapist is trying to hold the gait belt without the harness system, and they both fall down, and the therapist and the patient gets injured.
Well,
So this is
both of
really, this is really helping with that.
Do you want me to let you out? Yeah, so I really like this system because it's just so easy to pull on and off, and you feel great. 4 points of, that you clip in, very secure, rated for 500 pounds, and then super easy to pull on and off. And if you, so we'll switch often in therapy, so I'll pull this off and I'll walk with you like around the clinic to our next, thing to do. So this system's really, really cool, and it's one of the main reasons why this, clinic is special. The other, thing is the vestibular expertise and tools that we bring to the table to try to assess that system, because that's something that not every clinic, can do. So, and then our foot mapping and my, ability to treat lymphedema. These are things that help us to target all those systems of your eyes, your feeling, and your sight. Your sight, your feeling, and your vestibular system. So, any other questions? Yeah.
I have AFib, so usually when I do physical therapy, they would put a heart monitor on me. And that has to be monitored if my count is too high that day, they wouldn't let me do it. Is that something I would do here?
Yeah, I mean, that's exactly it. We always want to monitor your AFib. Do you have it on your cell phone, or how do you monitor it?
Well, I did it in the place, they
Oh,
monitored
okay.
it there, but I also have an Aura ring where I can monitor my heart rate.
Yeah, so my understanding is that we don't have anything to monitor heart rates here. That's something we could potentially get. But usually, if a doctor wants you to monitor your heart, from my experience, they usually give you a tool to do that. As you are discharged from hospitals, if they want you to continue to monitor that heart rate, or they have a system on you to where it can be remotely monitored by somebody else. So, if that is something that your doctor has prescribed for you, then we would definitely utilize that in therapy.
I have sciatica real bad and neuropathy from diabetes. Does this stuff work into any of that?
Yes, absolutely. So that's a foot screen. So we are looking into neuropathy tools because it's one of those hard things to treat and see immediate effects. But we also do foot screens to map your foot.
But that would be sciatica too?
So it can't be sciatica. Sciatica is sciatica can come from the hip or the low back. So we do a low back and hip evaluation to try to see where is this sciatica pain, where is the nerve getting pinched. So we try to see if it's getting pinched in the back usually, or if it's getting pinched between the piriformis muscle, or if it's somewhere else along the line. Yeah, so we do an exam. Those are two things that we deal with all the time in physical therapy, and those are issues that sciatica can really improve sometimes. Neuropathy can be a harder one. That's why we're looking into more tools to try to treat that. So. Yeah.
If you're working, I guess I should just use myself as an example. I'm working with the clinic. Do you send reports to the doctors at this clinic, or how does that work?
Yeah. So if the doctor wants reports, we send them off. We can email them to the docs too if they need that. But we always have to have our progress notes co-sign to continue treatment at a certain stage of therapy. So it's that like 30-day mark. So your doctor, or someone in the doctor's office, you know, usually is signing off, like maybe it's a physician's assistant that works for the doctor, but people have to sign off on that continuation of care.
And I have another question about the magic 12.
Okay.
The 12 weeks.
Yeah.
It's usually what insurance allows, it's 12 weeks. But if you indicate that there is progress being made, and there are falls happening, or there are things happening, even though the patient is exercising and doing what you're telling them to, do you ever extend the 12 weeks, or do you do
Absolutely,
12 weeks
yeah.
and take a break and then come back again, or how does that work?
It depends on the insurance. Some people pay more for their health care, so they get basically more in return, right? So some people it'll be easier for their insurance to approve things. Some insurances are gonna be very resistant to approving anything more than like a month of therapy, right? So it just depends on the insurance, and it depends on the diagnosis and the significance of the impairments and functional limitations. So the disability the person's dealing with. So, but bottom line is that, you know, 12 weeks is like, it's one of those, that's kind of like a big limit for a lot of people, but some people, if their diagnosis justifies it, they can get therapy for months and months, like, you know, 6 months, 8
That's
months.
once a week.
So usually we decrease the frequency over time. So again, like, most people are gonna stop before 12 weeks. That's why that's a magic number, right? Is because most people are done with therapy within that time frame, or
It's on the diagnosis.
or they're just doing one visit a week or one visit every 2 weeks to extend. Because most insurances will approve a number of visits, not a number of weeks. So if you have 20 visits approved, you can extend them out for 6 months, no problem. You just might have to come once every 2 weeks.
So if you have something like Parkinson's or MS, and it doesn't go away, I mean, it's not gonna go away, then theoretically, again, depending upon the insurance, your time with the physical therapist will be more, because you have more needs.
Yeah, I feel like as a physical therapist, I feel like it shouldn't be, I don't feel like progressive neurological diseases should be penalized, but, you know, I'm seeing more of that, yeah, so, and that's very discouraging to me. Like, we have to fight for one of our patients to get in here, and, yeah, I don't think it should be that way, but, what we do is we'll decrease the frequency of the visits to try to keep tabs on the person, and then, if they can't, you know,
Like every other week, or?
every other week,
So that they're seeing you, and in the meantime, they're doing their exercises.
that's what we want to happen, yeah. So we try to encourage people to be as autonomous as they can. And that's what I love about physical therapy, you know, it's the autonomy part, because that's quality of life. We don't want you to be dependent on us. But, you know, at the same time, some people need